Welcome, everyone, to this educational presentation from Professor Mohammadi's teaching archives. Today, we will discuss common pitfalls in neonatal neurology and how to avoid them in everyday clinical practice. Neonatal neurology is different from neurology in older children. The newborn brain is immature, rapidly changing, and strongly influenced by gestational age, perinatal events, medications, infections, metabolic status, and the NICU environment. Our goal is not to memorize rare diseases. Our goal is to reduce common clinical errors: incomplete history taking, rushed or inappropriate examination, failure to correct for gestational age, missing subtle signs, overcalling normal variants, delaying needed investigations, and poor communication. A careful bedside assessment, timely escalation, and clear family-centered communication can make a major difference in outcomes. Next slide, please. A safe approach to neonatal neurology requires a clear structure. The framework used in this presentation follows 4 practical steps. First, we identify the pitfall. Second, we understand why it leads to error. Third, we apply a safer clinical strategy. Finally, we reinforce the key bedside habits that help prevent the same mistake from recurring. This structure is useful because newborn neurological assessment can be vulnerable to both under-recognition and over-interpretation. Sometimes we miss early warning signs because they are subtle. At other times, we may overdiagnose normal developmental or transitional findings. The safest approach is disciplined and repetitive. Take the right history, examine the baby properly, interpret findings according to gestational age, observe again when uncertain, and escalate promptly when red flags are present. Let us begin with one of the most important foundations of neonatal neurological assessment: the perinatal history. In neonatal neurology, the history is often the diagnostic anchor. A newborn with hypotonia, seizures, poor feeding, abnormal tone, abnormal movements, or altered alertness cannot be interpreted accurately without understanding the pregnancy, delivery, resuscitation, and immediate postnatal course. Important clues may include maternal illness, infection, medication exposure, reduced fetal movements, difficult delivery, birth depression, low APGAR scores, need for resuscitation, hypoglycemia, jaundice, sepsis, or respiratory compromise. Missing these details can lead to misinterpretation of findings or delayed diagnosis. A comprehensive antenatal, natal, and postnatal history helps the clinician connect the neurological picture with the real clinical context. A structured checklist is one of the simplest ways to avoid omissions in neonatal neurological history. The clinician should ask about pregnancy complications, maternal medications, infections, fetal movements, delivery events, APGAR scores, resuscitation, cord gases if available, early feeding, glucose problems, jaundice, temperature instability, sepsis concerns, and any abnormal events observed by parents or staff. Open-ended questions are equally important. Parents may describe episodes, movements, behavior, or feeding changes that are not fully documented in the medical record. So the practical habit is to combine a checklist with careful listening. Review the records when available, but do not rely only on the chart. A complete history can prevent both delayed diagnosis and unnecessary investigations. Next slide, please. The key message remains that inadequate perinatal history is not a minor gap. It can change the entire interpretation of the newborn's neurological findings. For example, hypotonia after a difficult delivery and resuscitation may suggest a very different pathway from hypotonia in a well newborn with no perinatal risk factors. Similarly, abnormal movements in a baby with hypoglycemia, sepsis, or encephalopathy require urgent attention. The clinician should slow down, organize the information, document clearly, and reassess when the baby's state changes. In neonatal neurology, the story often explains the examination. Next slide, please. The next major pitfall is an improper neurological examination. A neonatal neurological examination is not simply a smaller version of the examination used for older children. The newborn state has a major effect on the findings: sleep, crying, hunger, illness, sedation, ventilation, respiratory distress, and gestational maturity can all change tone, reflexes, responsiveness, and movement quality. A rushed or unstructured examination may miss asymmetry, abnormal posture, weak suck, abnormal spontaneous movements, abnormal cry, or subtle focal signs. Conversely, normal immature findings may be misinterpreted as pathology. A safer approach is systematic. Observe first before touching the baby. Then assess posture, spontaneous movements, tone, reflexes, cry, feeding, and behavior appropriate for gestational age and clinical condition. Next slide, please. Gestational age is one of the most important interpretive filters in neonatal neurology. A preterm infant cannot be assessed using the same expectations as a term newborn. Tone, posture, reflexes, sleep-wake organization, feeding ability, visual alerting, and spontaneous movement patterns all mature across gestation. If corrected age is ignored, normal immaturity may be mislabeled as abnormality. But the opposite problem can also occur. True pathology may be dismissed as simple prematurity. The clinician should always ask, what is the gestational age? What is the corrected age? What neurological findings are expected at this stage? And is this baby following the expected developmental trajectory? Reassessment over time is often more informative than a single brief examination. Next slide, please. Subtle neurological signs are often the earliest clues to serious neonatal conditions. A newborn may not show dramatic focal deficits. Instead, the clinician may notice reduced spontaneous movement, persistent asymmetry, weak suck, abnormal posture, unusual eye movements, irritability, lethargy, abnormal cry, or brief recurrent events that are difficult to classify. These signs may be missed in a noisy environment or during a rushed assessment. A safer strategy is careful observation in a quiet setting, ideally before handling the baby. When events are intermittent, video recording can be extremely helpful for review by the team. The main message is that small signs deserve attention, especially when they are asymmetric, persistent, recurrent, or evolving. Next slide, please. Another common pitfall is mistaking normal neonatal variants for pathology. Some newborn findings may be benign or transitional. Jitteriness, startles, transient asymmetry, immature movement patterns, and nonspecific behavioral changes may look concerning if viewed in isolation. Overdiagnosis can lead to unnecessary EEG, imaging, medication, admission, and parental anxiety. However, calling something a normal variant should never mean ignoring it. It means correlating the finding with gestational age, perinatal history, glucose status, temperature, illness severity, and the overall neurological examination. A balanced approach is essential. If the baby is otherwise well, and the finding is transient, follow-up and reassessment may be more appropriate than immediate labeling. But if the finding persists, evolves, or appears with red flags, further evaluation is needed. Next slide, please. The next pitfall is ignoring or delaying investigation when the newborn is at risk. While unnecessary testing should be avoided, delayed investigation can be dangerous when red flags are present. Examples include neonatal seizures, persistent encephalopathy, focal neurological deficits, suspected central nervous system infection, severe hypoglycemia, abnormal head size, progressive lethargy, recurrent apnea with neurological concern, or signs of hypoxic ischemic encephalopathy. Investigations should be guided by the clinical scenario. Metabolic concerns may require glucose and electrolyte assessment. Suspected infection may require sepsis or meningitis evaluation. Suspected seizures may require EEG or amplitude-integrated EEG where available. Neuroimaging may be needed when structural injury or focal pathology is suspected. The key principle is simple. Do not wait for complete certainty when the newborn is at high risk. Next slide, please. Communication is not separate from clinical care. In neonatal neurology, communication is part of patient safety. Newborns with neurological concerns are often cared for by several professionals, including neonatologists, nurses, neurologists, radiologists, therapists, and primary care providers. The family is also a central part of the care team. If communication is poor, care becomes fragmented. Tests may be repeated, important information may be lost, counseling may become inconsistent, and follow-up may be missed. A clear plan should include the working diagnosis, the main concerns, red flags, seizure plan if relevant, investigation plan, reassessment timing, and discharge follow-up. Families should receive explanations in understandable language, with empathy and practical guidance. Good communication closes the loop and protects continuity of care. Next slide, please. Let us now summarize the golden principles for excellent neonatal neurological care. First, know normal development by gestational age and corrected age. Second, Observe carefully and repeat assessments because neurological signs may evolve over hours or days. Third, identify red flags early and escalate promptly when risk is high. Fourth, correlate every finding with the history and the whole clinical picture. A single sign should not be interpreted in isolation. Fifth, work as a team because neonatal neurological care is interdisciplinary. Sixth, support the family with clear information and empathy. Finally, remember that early assessment and timely intervention can influence long-term outcomes. The newborn brain is delicate and dynamic, and careful clinical attention can change a lifetime. Next slide, please. A practical bedside checklist helps translate these principles into daily practice. Start with the history: pregnancy, delivery, resuscitation, infection, medications, fetal movements, feeding, glucose, and jaundice. Then establish the context: gestational age, corrected age, clinical state, sedation, ventilation, temperature, and illness severity. Next, observe the baby before handling. Look at posture, spontaneous movement, asymmetry, alertness, cry, feeding, and abnormal events. Then examine systematically: tone, reflexes, suck, motor response, posture, movement quality, head size, and focal signs. Escalate promptly for seizures, encephalopathy, focal deficits, suspected central nervous system infection, or persistent deterioration. Finally, communicate clearly, document decisions, update the team, counsel parents, and arrange follow-up before discharge. Next slide, please. The take-home message is that neonatal neurological care is safest when it is structured, age-aware, repeated, and communicated clearly. Avoid relying on an incomplete history or a rushed examination. Respect maturation by interpreting every finding in relation to gestational age and corrected age. Look again when uncertain, because subtle signs may emerge only with repeated observation. Balance action carefully. Avoid unnecessary tests and labels, but act quickly when red flags appear. Close the loop through clear documentation, team communication, and family support. Every newborn deserves a careful neurological assessment. Your attention today can shape their tomorrow. Next slide, please. Thanks for watching.